Welcome to Observations, an open conversation about women's health. This is a space where physicians, patients, and other experts can sit down and have honest, evidence-based dialogue that cuts through the media bias and brings clarity back to maternal care and how we can care for both patients, mother and preborn child. With each episode, we will have real stories, real science, but also real questions about women's health today. From clinical insights to lived experiences, to aligned perspectives, and yes, also respectful disagreements. This is our goal, to bridge the gap between physician and patient, to empower informed decision-making, and bring back and elevate compassionate, fact-driven care. Now, a quick note before we dive in. Not every guest on the podcast is going to represent the views or positions of Applog, but we believe that having open and honest conversations are going to make us better. So, grab your coffee, settle in, and let's get into today's observation.
Hello, I'm your host for today, Dr. Christina Francis. I'm the CEO of Applog, the American Association of Pro-Life OBGYNs. Today, I'm so happy to have with us a friend of mine and a return speaker at our national conference, Dr. Kheriaty. Aaron, thank you so much for being here.
It's great to be with you.
Absolutely. So Dr. Kheriaty is a psychiatrist and author of over 100 articles and 5 books, including the forthcoming Making the Cut, How to Heal Modern Medicine, which sounds like it will be a very important and good book. He's a fellow and director of the program in bioethics and American democracy at the Ethics and Public Policy Center. For many years, he was professor of psychiatry at UCI School of Medicine and director of the medical ethics program at UCI Health, where he chaired the ethics committee. Dr. Kheriaty was a plaintiff in the landmark free speech case Missouri v. Biden. For his work challenging government censorship, the journalist Matt Taibbi has called him the most ambitious theorist of the censorship industrial age. Quite the accolade there, Aaron. Yes, so thank you so much for being here. We're at our national conference, which is in Seattle, Washington, for the first time ever. And we were just talking, and you said that you grew up here. You're from here.
That's right. Area. Bellingham, about 90 miles north of Seattle here. My sister's and her family's still here in Seattle, so I have family up here.
Very nice. And then you were also just telling me a story about applying to medical school. And of course, one of the things that Applog is doing right now, really focusing on, is protecting and helping guide medical students and residents, specifically pro-life medical students. Are you willing to share the story you just shared with me about your med school interview here?
Yeah, so I applied to the University of Washington, which would have been considerably cheaper than going out of state or paying private tuition for med school because this was my home state. And I had, the numbers and the credentials, I think, to get in. I got a very early interview at UW. And then when I arrived for my interview, I was interviewed, first of all, I was interviewed by a panel of 4 or 5 attending physicians at the same time, which was a little bit intimidating.
Yeah.
It was my first med school interview. And I was told, don't worry, they're not supposed to ask you about controversial ethical issues or religious issues. It's just, supposed to be about your qualifications. So I was totally naive going in and was unprepared for the fact that maybe 2 or 3 questions in, maybe 5 minutes into the interview, they started asking me about abortion and what I would do with a scenario where a 16-year-old girl with an unintended, unwanted pregnancy presented for treatment to me as let's say a primary care physician. And essentially I think they saw that I was coming from a Catholic university. My undergraduate work was at the University of Notre Dame. And I think they wanted to sort of assess where I was on the whole issue of abortion. And I tried to give an honest, but I wouldn't say non-committal, but just a little bit of an avoidant answer. I didn't want to get into the ethics of abortion in my interview. And they essentially kept pushing with that same scenario and kind of painted me into a corner as to whether I would do the abortion. Of course, the answer to that was no. And then started pressing me as to whether I would refer out to have someone else do the abortion, which I would have considered material cooperation with something that was evil and contradicted the ends and purposes of medicine. So
Absolutely.
I basically, my entire interview at the University of Washington ended up being about abortion for admission to their medical school.
Oh,
So I walked away from that a little bit dazed and confused, not sure
sure.
what had hit me. I was told later by a colleague that the University of Washington was doing abortions, performing and training on abortions even prior to the legalization of abortion under Roe. And so I think probably aside from the University of California in San Francisco, which is
Mm,
sort of a hub for abortion advocacy and
right.
abortion training, University of Washington probably comes in a close second. So
Mhm.
long story short, I didn't end up getting into the University of Washington. I ended up going to Georgetown instead. That was a great place for me, and I had some good mentorship there and some good experiences there. So it worked out for me in the end, but that was a sobering sort of
Mhm.
uh, introduction to the world of medicine for me, where it became very clear that for many people in medicine, for many institutions in medicine, ideology trumps any other considerations
Mhm.
regarding merit, qualifications,
Right,
right?
right.
What's really important
Yeah,
when you're trying to assess someone for, let's say, med school admissions
yeah.
or the residency training.
Right, right, absolutely. Well, and unfortunately, I think that stance and that way of assessing med school applicants for many schools has likely become even more common
Yeah.
even than since you entered medical school. And so, it's so important that we have groups of physicians like APLOG that are coming alongside of these medical students because, of course, you and I'm sure you're in agreement with this, we need pro-life students to be going into medicine. We need ethical students to be going into medicine so that we can start to shift the direction that our profession has really gone.
Yeah.
And I think at the end, maybe let's round back to that too, so that you can tell us about your newest book. But we have you here at the conference talking about abortion and its impact on mental health. And, one of the things that I think, speaking of medical students, is so important is that we equip them with what does the medical evidence actually say
Yeah.
versus what they might be learning in medical school or in residency or from the mainstream media. So that when they are defending life in medical school and in their practice, they can do it from a medical and scientific standpoint as well to say that abortion isn't healthcare, it's not good for women. Oftentimes, we hear abortion advocates claim that, again, abortion is essential healthcare, that there's zero, I heard this again recently, that there's zero mental health impact of abortion on women. Uh, you tell us, you published a paper last year in Issues in Law and Medicine
Yes.
about abortion and mental health. And so now I'm going to ask you in just a couple of minutes to recap for us what
Sure.
your entire paper said. But what does the evidence tell us about abortion's impact on the mental health of women?
Yeah, thank you for asking about that. And the paper, I would say, is very nuanced because it's based on expert witness testimony that I've given now in several cases related to abortion, where this whole question of the mental health outcomes from abortion was directly relevant to the issue at stake in the legal case. And when you sit down and you present your evidence in an 8-hour deposition with one of Planned Parenthood's lawyers who's nitpicking and going after you aggressively, you learn to be careful and nuanced in the way in which you assess and analyze and present
Yeah.
the data. But to make a long story short, what I present in that paper is essentially a couple of key conclusions. Number one, it's very clear that there is an association between abortion and several negative mental health outcomes, at least for many women. So I don't want to claim that every woman who undergoes abortion, I think every woman who undergoes abortion is wounded morally and spiritually in various ways, but that does not necessarily mean that that abortion is going to lead to a measurable negative mental health outcome like a mental illness, something diagnosable like depression, anxiety, a substance use disorder, or suicide. It's not the case for everyone, but it's the case for many women, that rates of those problems that I just named, depression, various anxiety disorders, drug and alcohol abuse and misuse, and suicide, both attempted and completed suicide, rates are considerably elevated in women who have had an abortion if you compare them to two different groups. If you compare them to the general population, their rates of those negative mental health outcomes are elevated. And then critics will say, well, we shouldn't compare them to the general population. We should compare them to women who have been pregnant and carried their pregnancy to term. And I think there's value in comparing to both groups.
Yeah.
But even if you compare it to the second group, women who are undergoing pregnancy, which itself has stresses associated with it, and sometimes negative outcomes like postpartum depression, the group that has an abortion versus the group that has a pregnancy that they carry to term, the abortion group has very significantly higher rates of depression, anxiety, substance use disorders, and suicide. Now, abortion advocates will then say, well, if you control for various confounding factors like pre-existing mental health conditions, those associations disappear. That's only partially true. There's still many studies that show a strong association even with good controls. And you also have to, if you control for too many of those confounding factors, you basically get a population of people that doesn't represent women who actually get abortions.
Absolutely.
Many of whom do have pre-existing mental health conditions. I recently did an expert witness case where essentially what was at issue in the case was precisely those women who had previous mental health conditions, because abortion advocates were arguing that the law in this state, which allowed for an exception for the life and health of the mother, but that exception was very carefully defined in the law, so as not to include mental health conditions. They were saying, no, it should include a mental health exception as well. And basically, once you do that, you open up the floodgates. That's what happened in the UK. That's how basically you get abortion on demand, because the doctor will simply say, well, the woman's experiencing psychological distress. If she can't get the abortion, therefore it's justified on mental health grounds. So it was very important to try to defend this fairly strongly pro-life law against this attack. And essentially, the plaintiffs in this case were arguing precisely on behalf of women who had mental illness. And then they were trying to get me to exclude in my testimony any study that included precisely the population at issue. So they sometimes talk out of both sides of their mouth when they're trying to analyze the data. Then the other thing that they will fall back on is, of course, association does not imply causation. Correlation does not imply causation, which is true. So then the next question is it abortion itself that seems to be contributing to these mental health outcomes, or are both things just correlated with a third factor that maybe we haven't measured, right? This is the constant challenge in epidemiology and social science research that we face. And of course, the best way to establish that abortion might cause mental health outcomes, or anything might cause something else, would be a randomized controlled trial, which is obviously impossible. You know, even abortion advocates would admit that would be unethical. And so we're never going to get that. But the next best thing would be a population-based study, large population-based study with multiple prospective time points. And we have two studies, one from the United States using the so-called AdHealth data, and another one using a very similar data set in Canada that basically followed adolescents into their 20s and 30s longitudinally, multiple time points. And those papers published based on both of those databases have also demonstrated negative mental health outcomes from abortion, and a cumulative additive effect with multiple abortions across time. So you can say, okay, look, the negative mental health outcome didn't precede the abortion, happened afterwards. And the study design allowed us to conclude with I think, significant degree of confidence that not only was there an association, but there was a causal relationship. And this has been done elsewhere in epidemiology as well. We've never done a placebo-controlled trial of cigarette smoking, and yet we know with confidence, based on a large body of research over time, that smoking not only is correlated with lung cancer, but smoking causes lung cancer, right? So there are ways to do this even outside of randomized controlled trials. So I think a careful and nuanced assessment of the literature would show conclusions that we don't need we don't want, nor do we need to overstate them.
Sure.
Like that all women are measurably harmed in terms of mental health outcomes by abortion. That doesn't seem to be the case. But a very significant number of women are harmed. And the strong correlation is associated with certain risk factors that are identifiable, including having a pre-existing mental health condition. And there's now, I think, sufficient evidence to suggest that this is a causal relationship and not just an association with a third factor. So yes, abortion for some women, for many women, seems to contribute to negative mental health outcomes. It seems to harm them in ways that go beyond just their physical health to include also their mental health. And that should be, although it's not, a part of the informed consent process when women are making this very difficult decision. And it needs to be acknowledged when we look at law and public policy as well. And so we have to bring this information to the courts in a way that's nuanced and credible. And so my study cites several review articles and meta-analyses. There's actually thousands of studies done on this question, some of them of low quality, but others of fairly high quality. And the studies looking at, you know, the best available evidence, I think would arrive at the conclusions that I just tried to sketch.
Absolutely. Well, and as you said, it's so important that that be a part of the informed consent process for patients. You know, of course, as physicians, that's a big part of what we do. Even if what we're recommending to the patient, we really feel like is the best option for them. It's the thing that's going to protect or restore their health the best. We still have to tell them about potential risks. And, you know, and women, of course, in the way abortion is largely being done now in the US, which is online with the abortion pills, and they're getting zero counseling whatsoever. But even when they're in a clinic and they're seeing, most times not a physician, maybe a nurse, you know, for their consent, they're not being told. They're being told, this is nothing, it will make your life better. They're not even being given any information. And as you said, we should never overstate our case. We should never say it's 100% of women that are going to have adverse outcomes. But that woman sitting in front of that physician deserves to know what her individualized risk is.
That's right.
And if she's got a history of attempted suicides, if she's got a history of severe depression, her risk is going to be exponentially greater for adverse outcomes after an abortion.
Yeah, and the risk is also very long-term. I mean, this is another aspect of this issue that I think is important for people to understand. Very often, the subjective sense of relief immediately after an abortion, if you look at just a time period a month or two later, a woman may report subjective satisfaction and even maybe a little bit of lowering of her anxieties. Let's say she had an unintended, unwanted pregnancy. This is presented to her as a quick and easy fix. And the initial reaction to the abortion may involve kind of some short-term relief. Right. And it's important to acknowledge that just at the psychological level. What happens with the negative mental health outcomes that I'm talking about, some of them can appear immediately. In other cases, though, they appear oftentimes 1 year, 2 year, even 5, 10, or 20 years out. They can resurface at times where the women maybe had not been thinking very much about her abortion, but then let's say she had an abortion when she was a teenager. 15, 20 years later, she gets married and tries to get pregnant and has difficulty achieving pregnancy for whatever reason, maybe from the abortion, maybe for another reason. And that can oftentimes bring up some of the unresolved guilt and grief and burden that she's been carrying from the abortion. Maybe it's seeing a sister who just got pregnant. That triggers that unresolved loss, grief, moral conflict, whatever it was, that perhaps has been buried for many years. So in my own clinical experience, time does not necessarily heal all wounds. And whatever short-term, you know, sense of, okay, I've taken care of this problem and now I can be free of it, the woman might get, the long-term burdens of that decision to end the life of her unborn child are very often not something she's informed of, not something she's aware of, and something that maybe even surprises her down the road when she finally has to face it and come to terms with that decision.
Absolutely. Well, you know, you talking about that reminds me of a patient that I saw a few years ago. I work as an OB hospitalist now. We cover inpatient consults. And I was consulted to come and see a woman for postmenopausal bleeding. You know, she's in her 60s and she's admitted for something else. And I go up and I talk to her, and I'm just doing my normal history, you know, that I always do. How many pregnancies have you had? Did you have any miscarriages? Did you have any abortions? You know, the normal questions we ask people. And she kind of hesitated when I got to the abortion question, and you know, I knew where it was going to go then. And she got tears in her eyes and then just openly started weeping. And I said, "Oh, you know, I'm so sorry." I sat down on her bed with her, and she said, "I did have an abortion when I was 20." And she kind of told me a little bit about it. And then she said, "You know, you're the first person I've ever told that."
Yep.
And here we are 40 something years later, and she's obviously still devastated by it. And, you know, I didn't get the sense that maybe it was the first time she'd sort of had an emotional reaction to it. You know, maybe in the privacy of her own home that had happened before, but it really struck me that here, you know, after 40 something years, not only was I the first person she was telling about that, but also that pain was obviously still so
Still there
acute for her.
4 decades later.
Yeah, absolutely.
I have had very similar experiences
Mhm,
clinically
mhm.
as well. I recall the case you described reminded me of another woman that I saw. It was also 40, 45 years after the abortion. She presented in the emergency room for depression and suicidality.
Mhm.
And in the course of my social history, I asked the same questions, even though I'm not an obstetrician. I asked, how many times have you been pregnant?
Mhm.
Uh, how many children have you given birth to? And if there's a discrepancy between those two numbers,
Yeah,
what happened
yeah.
with the other pregnancies? And then just a simple question to give them permission to grieve, because their grief and their pain has been forbidden by the ideology that says abortion never harms anyone.
Right.
And so just, okay, with the abortion, what was that like for you? For many women, it's difficult. What was it like for you? It was the same thing.
Yeah.
The emotion that came out there. She admitted she had never told anyone else about this, never talked about it. But almost 5 decades later, that grief and that pain was still there right below the surface.
Yeah.
Was it contributing to that particular episode of depression? Hard to say with certainty,
Sure.
but it certainly wasn't helping.
Yeah.
And the fact
absolutely.
that the emotional reaction to the abortion, I mean, that was the first and only time she teared up during the entire interview. And the interview was all about being suicidally
Right.
depressed.
Yeah.
So, you know, it's not implausible to believe that, even, you know, almost 50 years later,
Yeah.
the impact of that decision was a burden that she was still carrying all those years later, which is
Absolutely.
just tragic.
It is really tragic. And I think, you know, as physicians in our training, I'm sure yours was the same way. You know, we're kind of taught to rubber stamp the abortion. You know, when patients ask for it, you're not to give directive counseling. You know, if they want the number for the abortion facility, you're to give it to them, that sort of thing. I think one thing we need to remember is that we are potentially helping spare our patients from this anguish for decades if we can talk to them about the realities of what might happen after an abortion.
That's right. Yeah.
But also when we're seeing women after the fact, acknowledging, as you said, that this is oftentimes very hard and many women are traumatized by it. And I think in a way, normalizing that for the patient, to say you are not abnormal in this, so that she feels comfortable, obviously opening up with us and working through that. But also so that, you know, maybe that helps release some of that for her and she'll be able to start working through that. You know, we're withholding that healing from our patients when we don't ask them about it.
That's so important. That's so well said, because, you know, they're carrying this burden, and then they're carrying the additional burden of, I'm not supposed to be carrying this burden. I'm not allowed to feel this way about my abortion. That's the message that they're getting from society, from the medical establishment very often. And so just, again, normalizing it in the sense that acknowledging that many people who have pregnancy loss, and you can also put it in the context of both abortion and miscarriage, involve complicated forms of grief and can be difficult.
Yeah.
And so putting it in that context of many women experience pregnancy loss, whether through spontaneous miscarriage or because of abortion, as difficult. You're not the only one who feels this way and who may be bearing a burden of grief, in the case of abortion, complicated maybe by guilt, by moral injury, by the fact that this is something that I chose to do and perhaps I could have chosen otherwise.
Yeah, absolutely. Going back to what I think many medical students and residents and are being taught about, not only that abortion doesn't negatively impact mental health, but being told that if we deny abortions to women, that will negatively impact their health. And of course, that's all based on the cadre of studies that were done out of the Turnaway cohort, which showed actually that women who were denied abortions because maybe they were too far along in their pregnancy for where they were at to get an abortion, actually, if you followed them out, as you said, immediately they might be upset because they felt like they needed or wanted an abortion and they couldn't get it. But if you follow them out 5 years, it's something like 97% of women said, I'm actually really glad I didn't have an abortion. I'm so thankful that I have my 5-year-old here, So that goes away. But I think that the reliance upon studies like that by the medical establishment, the National Academy of Science report that they did on abortion, when they were talking about abortion and mental health, basically just looked at the Turnaway studies, if I'm remembering correctly, and decided to ignore a lot of the other things.
Let me say a word about the Turnaway study, because again, that's always the one that abortion advocates cite. Okay, so this was a study that was funded by abortion advocates. It was published in most of the studies based on Turnaway, most of the papers are published in a journal called Contraception, which is funded by abortion advocates. The researchers were funded by the same foundations, Hewlett Packard. So it's the
like
study
conflict of interest.
It's like conflict of interest,
That's
which I mentioned some of this in my paper that we mentioned at the outset. But if you actually look at the methodology of the Turnaway study, it was a small study. It's been milked for a whole several dozen publications based on one study that all more or less say the same thing. But it was about 1,000 patients, and the attrition rate in this study, basically only a third of the women who were approached agreed to participate. Of those, only half of them actually completed this study. So you have, if you take all the women who presented to the clinics where the study was being done, and you present findings based on only 15% of them in the end, you have what's called a selection bias.
Absolutely.
And there's various papers and various sources of evidence that suggest that women who have negative experiences with abortion are precisely the ones who don't want to participate in these kinds of studies, which is always going to therefore skew the studies in the direction of the cohort that seems less harmed by abortion. So an 85% attrition rate in this study is pretty, very seriously flawed. Even a 5% attrition rate can, invalidate the findings of prospective studies. So that's a very serious problem with the study. Another problem is that basically the employees of the clinic were allowed to choose which women they approached and which women they didn't approach to encourage them to enroll in the study. And again, you can sort of size someone up when they walk through the door. And if it looks like a woman is already experiencing some level of moral ambivalence or inner conflict or psychological distress, hey, maybe we're not going to ask her to participate because, we don't want to bother her. She looks pretty upset. Right? Well, that's going to also skew the findings in the direction of excluding precisely the people who are most harmed by abortion. So I think a careful analysis of the Turnaway study suggests that there's serious flaws and problems with the study. And then even if you take the study's findings at face value, if you put them in the context of all the other research literature, you have to ask the question, why did this one study seem to come to a different conclusion than so many other studies, including review articles and meta-analyses Coleman's, for example, that included 800,000 patients, 160,000 women who have had abortions.
Yeah.
Why does this study of 1,000 people, why are we going to present it as though it trumps every other piece of research out there on this question?
Right. Yeah. No, such a good point. And you're referencing Priscilla Coleman's work. Of course, she has done yeoman's work on abortion and mental health, and really analyzing the deficiencies of the whole turnaway cohort. I think the fact that major medical associations, the APA, I think still does, ACOG certainly still clings to that study in particular. To say that there's no impact, I think really shows how just ideologically driven our medical associations have become. And so I think just in sort of wrapping up here, can you tell it with that perspective, can you tell us a little bit about your new book and maybe a little bit about the work that you're doing at EPPC? I know your work at EPPC doesn't necessarily overlap with this in particular, but I know that this is work that you have done and something that you care very deeply about.
Yeah, so the book that you mentioned in the bio and the introduction, which when I sent that to you was forthcoming, is now out.
It's now out.
So
my apologies.
That's my apology. Just came out a couple of months ago. And so it's called Making the Cut: How to Heal Modern Medicine. And the book does three things. It's in part a medical memoir of my time in training. It's a book about med school and focused on patient stories and kind of the wonder of discovering and learning the practice of medicine, which is such a beautiful calling and vocation, a beautiful thing. Built around that is my presentation of kind of, this is what a sound philosophy of medicine looks like, that medicine has intrinsic ends and purposes, always and only aimed at health and healing. Medicine is not just a set of techniques that can be put to any purpose or any use that we want. Right. So medicine is for health and healing. It's not for killing and taking of human life, as in the case of abortion or doctor-assisted suicide and euthanasia. Medicine is not meant, to reconfigure a healthy human body or to destroy or amputate healthy human body parts, as in the case of sex rejecting procedures. Traditional Hippocratic medicine is aimed at health and healing. And so in the context of that kind of philosophy of medicine, I attempt to critique contemporary healthcare systems and look at what's gone wrong, not just in the individual practitioners here and there in medicine, but in the system as a whole, which in many cases has been captured by various ideologies that are foreign to the practice of medicine and foreign to sound medicine. So the book is critical of contemporary healthcare, but I think that aspect of the book is hopefully balanced out by, look, this is what medicine is and could be and really should be, and this is what we need to do to sort of get back to a sound practice of medicine that I think patients are hungry for, and physicians are wanting to provide. Everyone senses there's something wrong in contemporary healthcare. And if you look at the outcomes, like the chronic disease epidemic, we're spending twice as much as any other developed nation on healthcare, and we're barely breaking the top 50 in terms of health outcomes. We have this epidemic of chronic disease that medicine seems powerless to fix. So even setting aside sort of the lightning rod controversial issues like abortion and euthanasia, and just looking at is medicine achieving the purpose that we claim, we're not doing a very good job, right? The system is broken down in certain important respects. So my book is an attempt, you might say, to sort of diagnose that and then offer some suggestions of what healing the healthcare system itself might look like.
Amazing. Well, I'm excited to read it, and we will definitely put a link to where you can get your book in the show notes. I know people will be very interested in that, and it just is so great for me to know that I have partners like you in this fight that we're in to, Avalog's big push this year is forging a new path forward in medicine to return us to life-affirming healthcare, which, as you just said, I think is so much more than the abortion issue or the euthanasia issue. It really is getting us back to what is the purpose of medicine, which is health, healing, and wholeness. And I agree with you. I think we're not doing a great job as a healthcare system right now of doing that. And I think all of us as physicians sense that. I think that's why our physician burnout rate is so high.
Exactly. Yeah.
Because we're not doing what we were meant to do
Right.
as physicians. And so so wonderful to know that I've got a partner like you, a colleague like you, and in this fight as we really work to restore a respect for life in medicine. So Erin, thank you so much for joining us on Observations today. Thank you so much for being here at the conference to speak to our participants who are here today and for speaking to our Observations audience. Awesome. Well, thank you guys so much for joining us on this week's episode of Observations, and we will see you next week.
We hope that you enjoyed today's episode of Observations and that it broadened your perspective on women's health and how we can care for both patients, mother, and preborn child. If you like this episode, make sure to give us a 5-star review where you can find your podcasts. Make sure that you like this on YouTube and subscribe to our channel for more episodes coming up. And if you have any suggestions on any topics that we should cover or guests that we should have on, make sure that you email us at media@applog.org. Again, thank you for joining us for today's observation, and we'll see you in our next episode.